Well, I will be speaking on the macular hole in different scenarios. First of all, this is a case of a simple macular hole. As you can see, after doing the BVG staining, it's in the high magnification and recite lenses. It's pretty easy to peel the ILM, and we always try to peel it from arcade to arcade, because in case of a failed macular hole, we need to repeel. So in the primary case only, it's always better to peel as much as possible. So this was about the simple macular hole. Now, large macular hole, this is a very common scenario we come across. Obviously, this is a comparatively older video where the inverse peel, we didn't start the inverse fill. So this is one of the methods we can try for a large macular hole. This was epiretinal membrane along with a large macular hole. So once we peel this ILM along with the ERM complex, you can see it's quite a large macular hole. So what we can do, we can actually drain it from the edges of the macula. We need to be very careful. And many a case, we actually can close a macular hole on table, as in this case. A large macular hole actually closed on table. Now, nowadays, what we do mostly is inverted flap technique for a large macular hole. This is what we do. We take the ILM, remove it, and leave it at the edges of the macular hole so that it falls on the macular hole and serves as a scaffold on which the neurosensory retina grows and the macular hole closes. So first of all, the most important part is to keep a small island of ILM along the edge of the macular hole, and then later on we can actually have a concentric peel and increase the area of ILM peeling as to reduce the tangential traction. Can we have the music? Around the macula. It's not mandatory to tuck in the ILM. It's better not to do it because it's one rather tucking next is the input. Sometimes the last scenario, sometimes the primary surgeon is not. You don't know how much peeling has been done, so actually study and see how much peeling has been done. And with this area of the peeling from arcade to arcade. The last case had a type 2 closure. So this is the different scenario of macular hole, which can be done easily with this newer instrumentation, and especially the weaving system, which allows a much predictable outcome. Thank you.
Excellent, Aniruddha. And have you tried multiple fluid air exchange in cases of failed macular hole?
Yeah. First of all, we see that whether the peeling has been done as much as possible, and then fluid air exchange multiple times actually helps the hole to get closer. And especially if you drain from the edges, it can close on the table itself.
Don't you think it's a little riskier to you drain from the macular fluid from the macular hole?
Yeah, you need to be very careful. I showed one video where we could actually close it on table.
Yeah.
Because I think it all depends how much you are seeing. If your visibility is good, the chances of complication is much less, because you can do a precise work.
You have to have a good visualization system. Yes, that's true. And another thing, and how far you want to peel? Let's say primary idiopathic macular hole, how far you want to
I generally peel arcade to arcade in all cases.
And what's your choice of inverted peeling versus normal peeling in idiopathic
nowadays, frankly speaking, we are doing more of inverted peeling. We don't want to take a chance.
Yeah. Yes, that is true.
Anything above 400, 500 microns, inverted peeling would be a better choice.
And to Sudipta, do you think in cases of LMH and the lamellar hole related epiretinal proliferation, do you want to peel ILM as far as he does in normal idiopathic macular hole peeling? Is there any difference in ILM peeling in those cases with epiretinal proliferation?
ILM peeling in LHP.
Yes.
So, see, I think we initially used to do only the membrane removal, leaving intact the ILM. But I think in macular surgeries, if you are getting close to macula, we have a macular pathology, it's always better to handle the ILM also, to remove the ILM. Now, if you want to make a flap or you want to remove in toto, that will probably come with experience. But it's better to handle ILM in these patients.
Okay, so you recommend ILM peeling in those cases?
In all patients. These are actually
I showed all the surgeries in the recite lens, and the macular peeling is done in a high magnetic lens, not the contact one, the recite one.
You have a different macular lens by which you can, and you can have the opportunity to put a macular lens also, whichever system